Hello, this is John Kanelopoulos from our center here, the LaserVision Ambulatory Surgery Center in Athens, Greece, and clinical professor of ophthalmology at NYU Medical School, New York City, New York. Here's a young gentleman. He's in his early 40s. You can see he has phimosis of his left pupil and intumescent cataract. And what's worrisome is you can see the anterior capsule is curled, is wrinkled. He has a laser iridotomy. And his cell counts are pretty good, although he does have polymegathism, long history of uveitis in that eye, quiet at the time, so we'll endeavor to do cataract surgery. Inadvertently, he has very significant astigmatism, 2.7 diopters. So you know what I'm thinking. We're going to plan, since 90% of our cataract cases involve toric intraocular lenses, we'll try and employ this tool for this young gentleman in order to optimize his visual acuity. Our classic 6 o'clock mark in the implantation axis that comes from the toric Acrosoft calculator that we saw earlier, and we'll rinse, and then we'll first try and resolve the phimosis. And the reason that I'm showing this case, besides the fact on how to deal with a cataract of this form, and we'll see the technical intricacies that will come up with the procedure, is also a nice means of using a pupil dilatator such as the brilliant Malyugin ring. Boris has contributed immensely on this aspect in anterior segment cataract surgery. I think currently it's the international standard as the most easy to use in and out ring to obtain good pupillary dilatation during the procedure and have a safe cataract extraction. So we're filling the chamber with viscoat here after a clear cornea incision. I'm going to use a Kuglin hook and a Sinski to go in and lice carefully, pulling from inside the pocket that I've created out the synechiae between the iris and the anterior capsule. You can see that there's a pupillary membrane above the anterior capsule that needs incision. I have a small nick to it, and we can see through it the intumescent cataract. I'm going to place blue stain under that pupillary membrane, hoping that it will deposit itself onto the anterior capsule, and then come in with scissors, as the pupillary membrane is quite tenacious. So I'm here with Vaness scissors, enlarging what is the pupillary aperture from this inflammatory, most likely in origin. We did not follow this patient during his uveitis bouts. He came to us so when his vision was at the just light perception level and with a very progressed cataract. I'm going to try and first stretch the pupil with my two Kuglin hooks now. I have an open pupillary aperture, and this is my standard procedure. Usually I can deal with 90% of my cataract procedures with just stretching and intracameral adrenaline or epinephrine, which is the Greek term for it. Obviously, being in Athens, we prefer calling it epinephrine more. So we're seeing that number one goal achieved with our blue dye staining the anterior capsule. I am stretching the iris, but we can see that the iris in general is very fluffy in this patient, and it's really non-reactant to dilatation, not the drops, dilating drops, nor epinephrine that we're going to employ. It's almost irresponsive, most likely a sequela of the chronic inflammation and the repeated episodes of uveitis the patient had. I'm going with my irrigation aspiration to clean up the field, remove the residual blue dye, and we can see we basically have a non-reactive to dilating drops pupil. I'm going to clean all the blue dye from the chamber. We know that it's slightly endothelial toxic, but mission accomplished as far as it staining the anterior capsule in this patient very nicely. We can see the blue color, and it also attenuates the folds on the capsule, underlining that this is not just an intumescent cataract, but a cataract that has shrunk in volume. So probably at some point part of the lens cataractous material leaked out from the capsule. He may have gone through some phacoanaphylactic bouts, and we're dilating here the pupil with viscoelastic. This is not, I don't feel comfortable proceeding with my phaco procedure with a pupillary aperture so small and the iris so floppy as you saw before. So we're going to pull out our disposable Malyugin ring from our cabinet, use more viscoat to enlarge the pupil as much as possible, also fill the anterior chamber, and we're coming in here with a Malyugin ring inserter. See how beautiful and easy, and this is a key element of this becoming so successful as a surgical tool for the everyday anterior segment surgeon. The little curl of this proline continuous wire, if you may, will also serve as a holder for the iris. So with gentle control, we can get all first three levels of fixation, and we're left with a residual spring. I have not used it much, probably 30-40 times, as I most of the times can get away with dilating the pupil with epinephrine, stretching as we saw before with Googling hooks, or a collar button forceps. And thus this may be a novice approach to the Malyugin ring. So we'll engage the third loop of this proline ring, and then I'll use the collar button forceps to engage the last and most near to my clear cornea incision loop, center the Malyugin ring, and here I have a pupillary aperture of a good 6 millimeters. I'm going to try and incise the anterior capsule with a cystotome without any success. And of course, all the times that incising the anterior capsule by mistake come in mind here. So I'm going to use the Van Ness sutures to go in a more radical way to cut through the very tenacious anterior capsule. I need some resistance or something to fold the anterior capsule. So here I am, in theory, scratching my head, adding a little bit more viscoat. The chamber is not too deep, so I'm very careful. We want to preserve the nice and field count that we saw previously. And we're going to, by stretching the anterior capsule more, go more vigorously with my cystotome to incise the capsule. But we can, number one, see how much pushback we get from the anterior capsule, showing that the capsular bag is nearly half filled. So eventually I'm able to go through the very hardened and tenacious anterior capsule. Number two, with these manipulations, I'm confirming that a large quantity of the lens material in this, what probably started as an intumescent cataract, has been lost down the line. I have now space to fit through my Van Ness scissors rather, and do a scissors capsulotomy, as performing a continuous curvilinear capsular access will be near to impossible with the anterior capsule in this physiologic condition. I'm going to use better access for my paracentesis, so I'm going to enlarge my paracentesis from 1 millimeter to a 2.75. Low methyl cellulose gel on the surface to improve my optics. Always like it in patients that are treated with just anesthetic drops, because it reduces the spraying of the surface with BSS that usually surprises them and have them blink. This is not the case here. We're operating under peribulbar anesthesia, so I'm using my Utrata forceps to grasp the anterior capsule and enable me to get a second point of fixation. You can see how difficult it is, and I prefer to play this real time, as painful as it may seem to the observer, because this is real operating time, and you're seeing eventually me grasping the edge of the opening that I was able to create with my cystotome. I'm going to dig in with my scissors a little bit better in order to create a edge in the anterior capsule and leverage for my forceps to enable me and create a pathway for us to remove this lens. We're all appreciating the facility that the Malugin ring is offering us through these manipulations. So eventually, when nothing else works, we're going to incise the anterior capsule with the keratome. So now the keratome is a lensotome, since we're cutting through the, or a capsulotome, since we're incising the anterior capsule with the keratome blade, and thus creating an edge, which now I can grasp with my Utrata forceps and try and create a continuous capsulorhexis. You can see that that's still not possible, but I do have room now to go in with my Utrata forceps and complete the capsulorhexis, or capsulotomy better, manually. I'm going to grasp an edge of this very tenacious anterior capsule. As you can see here, since the capsule is so thickened and there's the capsular bag is devoid of a large volume of the lens, I'm going to, by fixating the anterior capsule with the Utrata forceps, use my keratome to incise manually enough of the anterior capsule. So I'm performing a blade capsulorhexis. Since the cystotome is unable to perforate through this very tenacious capsule, I'm almost halfway through, creating sort of a circular central defect to the anterior capsule, which I will complete with my Utrata, actually my Vanas scissors, through the main cornea incision, and sharing with you some of the intricacies of this particular uveitic eye, which, as we mentioned before, has probably gone at some point through a stage of intumescence of its lens, and following that, escape of the protein material through the intact capsule, and perhaps maybe phacoanaphylactic stage. In my opinion, the lens should have been removed a long time ago, at the beginning of the iridocyclitis or uveitis episodes. I'm pulling back here the capsule opening that I've created, the flap, and you see how with just aspiration I'm able to pull out a lot of this denuded lens material, crystalline lens material. It's not necessarily hard in texture, it's more thickened, whitened, a peculiar type of cataract that I have not encountered very often. I may have treated, throughout my experience with cataract surgery, maybe 3 or 4 cases. Usually these eyes tend to have either a liquefied white material, typical for cataract in an intumescent stage, or hard material that requires a lot of phaco power. We're seeing here that I'm not using my phaco tip, I'm just using my irrigator aspirator, and I'm able to perform a just irrigation aspiration removal of whatever was left from this intumescent cataract. So this is the reason I decided, this being a very particular case to go real time in the manipulation, and I'm working by manually. I'm holding the anterior capsular flap created with my hand to avoid having it engage with my irrigation aspiration tip. I'm bringing the forceps with the flap in to help emulsify the parts of the lens absorbed, and we're finally starting to see some red reflex, some light at the end of the tunnel, and the gratification that our procedure is advancing very nicely. I mentioned before that, of course, the easy way is to be a little bit more aggressive with the capsular bag and go with a Socus placed lens or a three-piece lens of larger diameter. I felt that I want to engage in this patient with the possibility of using a toric lens, since we saw that the indigenous amount of astigmatism is quite large. So we're done and removing all the lens material to include the cortex, and we will finish with trimming what's left of the anterior capsule, and I'm going to fill here the capsule bag with methylcellulose at this point, as I want to remove as much of it possible at the end of the procedure. And we'll go and confirm our lens power after, of course, we will manually trim that flap of anterior capsule that was left behind with my Van Ness scissors. I know it does not look very pretty in comparison to a continuous round curvilinear capsular axis. Always wondered how something curved can be linear. I would go more with circular, but in any case, will not change ophthalmic nomenclature here just because we're native in Greek language that is used in most of the nomenclature in medicine in general and ophthalmology as well. So I'm trimming here that last tongue of anterior capsule, making sure it will not obstruct my pupillary aperture postoperatively. You can appreciate how tenacious that capsule had become through the bouts of inflammation and possibly the phacoanaphylactic stage of this hypermature cataract. Finishing filling up the capsule bag, and obviously wanting to do the best possible job here, I'm going to still trim those loose leaflets of anterior capsule with my Van Ness scissors rather, and at least from my point of view, leave behind the capsule bag with the least possible means to obstruct the pupillary aperture down the line. Of course, this procedure will do nothing for the uveitis that the patient is suffering from. We've had good experience with the acrylic lenses being tough through uveitic episodes. I'm going to try and coming with my split irrigation aspiration, since I visualize there's some cortex left under the main incision. So I'm irrigating with the irrigation probe through my main incision, and through my paracentesis I have a split aspiration probe, and I'm going to try and remove some of the lens material that I visualized through these last manipulations as much as I can, of course, always keeping in mind that I want to keep intact the capsule bag to place my toric intraocular lens. And here's the lens unfolding in the capsule bag, and we'll dial it into the markings, the desired markings beforehand, making sure that the trailing haptic will also expand within the capsule bag. We'll get good centration of the lens. And then, of course, we'll finish with removing the Malyugin ring, for which, as I mentioned before, I only have good things to say as far as my personal clinical experience, which is also the global ophthalmic community experience, with it really expanding the safety and accuracy capabilities for small pupil phacoemulsification and intraocular lens implantation. So we're removing the residual viscoelastic here, which is mainly methylcellulose at this stage. Another important step to remove as much as possible, and we'll go in with our Sinskey hook to dial out the loops of the Malyugin ring, disengage these loops from the iris, the pupillary aperture, and it's actually the collar button and I'm engaging it back into the injector and pulling it out from the eye. See how nicely this can be done. A very elegant ring. I'm going to finish up removing the residual viscoelastic mycal to attain meiosis. Through our procedure, the main incision and all the manipulations with the Vaness scissors, etc., is not watertight. So I'm also going to share with you my mattress suture, aiming to not create any astigmatism. Is meant to just keep the upper and lower lip of the clear cornea incision tightly bound. Of course, rotate the knot and leave it in minimum week, maximum month, until the main cornea incision heals, and we can see how elegantly it keeps the eye watertight after cataract procedure, and how we have finished this very challenging case without traumatizing the iris much. We resolved the pupillary membrane, the very, very advanced cataract. Hope you found this interesting. Definitely a pleasure to share with you. This is John Canalopoulos signing out. Thanks so much.